how to like, okay. So today we're going to talk about mild cognitive impairment from its clinical viewpoint and also its related public health issues. So for decades, mild cognitive impairment has largely been ignored due to its lack of typical symptoms, similarity to normal aging, and not enough self-reporting and awareness. So a little bit background of introduction. So mild cognitive impairment is a stage between aging and dementia. It's difficult to estimate the prevalence due to different criteria across studies. So usually, in general speaking, it's about 15 to 20% of people who aged 65 years old and over who have MCI. So the annual rate of MCI progresses to dementia usually varies between 8 to 15%. So can you guys see my, like, the cameras of different faces on my screen? Or like, I'm not sure how to remove it, like put it into another, oh, it's right here. Okay, all right. The technology stuff. So this is a study done by CDC. CDC collected data from nationwide, there's something, let me see. Collected data from nationwide from 2015 to 2017. So it presents the characters of middle-aged and older adults, those aged 45 years and older and who reported subjective cognitive decline status and one or more chronic diseases. So the population was divided into two different groups. So one less than 64 years old and another group of over 65 years old. So we can tell that patients with a different chronic diseases have different self-reporting rate of subjective cognitive decline. It's interesting to see that people who aged 65 years old with the SCD are more likely to have arthritis. The second highest one is diabetes. So the reason behind it is unknown. Maybe it's simply due to the data collection bias or some other reasons. But this data, it doesn't give you a p-value, so we do not know whether the difference is significant or not. Here is a picture. It's a general view of the prevalence across states. So 20 states, including DC and Puerto Rico, had a prevalence of cognitive decline reporting among those with one or more chronic diseases that were higher than 20%. And this is also the same group of population who had discussed their cognitive issues with healthcare professionals. So although nearly half of them, like around 48% of adults aged 45 and older with more than one chronic conditions and subjective cognitive decline reported discussing their issues with a healthcare provider. However, adults without chronic conditions were less likely to discuss their issue with a physician or other healthcare providers. So this is a public health issue that we should be aware of, and to figure out the reason behind it and raise the awareness of the cognitive issue in the public. This is something we should focus on in the future. So here are some risk factors for mild cognitive impairment. After a brief review of the public health background, so we are going to talk about its clinical aspects and its challenging issues of MCI. Older age apolipoprotein E4 allele and lower numbers of years of education, or some other chronic conditions like diabetes, hypertension, or dyslipidemia, or cardiovascular diseases. These are the risk factors for mild cognitive impairment. Also some like systemic inflammation and neuropsychiatric conditions like depression, anxiety, or apathy. These are possible risk factors for MCI as well. Okay. Here are some protective factors as well. For example, higher educations, if you speak like maybe 2 or 3 or even 7 different languages, it's a protective factor from MCI and dementia. Also some cognitively stimulating activities like poker, or maybe building blocks, or magic cube also can help you to protect you from dementia. But personally, for me, I wouldn't recommend the magic cube. It's so hard for me, so it may even add frustrating. Also, some physical exercise like running or jogging, or some other like swimming. These exercises are benefit as well. Dietary factors like mono and polyunsaturated fatty acids. And here is an interesting study from Cornell University, and it's supported by NIH. It's a National Institute on Aging. It's supported by NIH and NIA. So it's a Mediterranean diet study. So researchers did baseline PET scan of people who had a Mediterranean diet and also who had a Western diet. And then they repeated the scan 2 years later. So the brain scans in the beginning showed that people who had a Western diet already had more beta amyloid deposits than those who ate Mediterranean diet. So the brains of those who ate a Western diet also showed a lower energy use. So both of these differences suggest the early development of dementia. So there is a picture of the brain activity in the right corner. We can tell that on the left side, the brain activities is higher compared to the right side. So left side is a lady who had a Mediterranean lifestyle diet, and on the right side there is the same age lady who had a Western diet. But the study only collected the data from 70 people. It may have some sample size issues or data collection bias as well. So here are different subtypes of MCI. Though the first one is amnestic MCI. It primarily affects the memory. So patients will usually forget about important information such as recent events or conversations. And the second one is non-amnestic MCI. So it means that people primarily has something other than memory issues, like other domains like executive function, language, or visual spatial skills. So MCI may also consist of single cognitive domain, or it can have multiple cognitive domains as well. Here is a subjective assessment for MCI. Physicians should always take history from the patient and from the family member or other caregivers to have a view of the big picture of the patient. So some patients with mild dementia or cognitive impairments, they are more aware of their memory deficits, but this is not the case in the severe demented patients. Physicians should also focus on changes in daily activities like financial management, whether the patient is getting lost in their neighborhood or the patient has some word finding difficulties, etc. Only subjective assessment is not enough to give a firm diagnosis of MCI. So we want to do some objective assessment as well. Sorry. The first one is a mini mental status. Usually it's often used in the CS exam. I think a lot of students, they know that. Usually the questions are like, what's your name, age, and what year is it? Where are we right now? And give the patient a word and ask he or she to spell the word backward for you. And also ask the patient 3 different words, and then ask the patient to repeat it 1 and 5 minutes later. So these are, this is a very simple and fast way to test the mental function. The next one is the MOCA test, Montreal Cognitive Assessment. It's a more accurate test for cognitive impairment by examining different parts of mental function, such as executive, naming, memory, attention, and language. So there is a picture on the right side. This is the MOCA test, exactly what you see on the MOCA test. Usually you would expect, like in a normal person, the score would be higher than 26 and more. So the next test is a mini cog test. This is a picture of mini cog test. Again, it's a simple and fast way to test the mental function. Usually patient can finish it within maybe 3 minutes. The normal cutoff point is 3. So if it's over 3 out of 5, then you are good to go. So here are some important concepts of daily activity instrument. The first one is instrumental activities of daily living. It's ADLs. So it contains financial management, medications, and cooking, housekeeping using places like telephone, TV, whether the patient can do shopping by him or herself, or also some extracurricular activities as well. And there is also another concept called activities of daily living, ADLs. This is something very basic that a person need for daily life, like bathing or brushing teeth, grooming and going to the bathroom and getting dressed, mobility or eating. So we will mention these concepts in the later slides as well. This is a criteria for this is criteria for mild cognitive impairment from NIA and Alzheimer's Association. So usually, in general speaking, patients with mild cognitive impairment, they may have some deficits in performing ADL or IADLs, but they are less efficient to perform these activities. But in general speaking, they are still dependent. They don't need like much help from a caregiver or social workers. That's the main difference between mild cognitive impairment and dementia. So this is the procedure of the diagnosis. The first step, you want to get the history from the patient or his or her caregiver, like ask the patient, have you ever noticed any changes in your memory or like cognitive function? Can you still manage your finance, or like can you still like taking your medications, like at what dosage? And you also want to make sure like if the patient has some neurological symptoms like vision, hearing changes, or abnormal gait, or imbalancing issues. Also, you wanna like rule out some psychiatric problems like depression or anxiety or any other like personality changes or etc. The next step, you wanna like rule out other medical conditions. You wanna check like thyroid function, vitamin B12, or maybe folate deficiency. And you wanna do the cognitive assessment as well, like MOCA or mini-cog test. So this is a general like overview of the procedure, but it may different in different clinics. So MCI and normal aging. MCI patient may have problems with balance and coordination, and they may repeat a question or story multiple times. They cannot remember the recent conversation. They may have difficulty following multi-step directions, like executive function is impaired. Also, they may have some difficulties with IADLs. So in normal aging, you wouldn't see a very severe impairment in these different functions that we should be aware of the difference between MCI. Although there's no clear cut point, but we should be aware of these changes, especially in elderly people. So MCI and dementia. Dementia is definitely more severe than MCI. Most of the time, ADLs, like very basic daily activities, they are impaired, such as bathing, brushing, like going to the bathroom. Patients are more independent. They need help from caregivers and other, like maybe social workers. These are the very important differences between MCI and dementia. So this is an evolution of the diagnosis criteria of MCI. So since 1979, things have been changed. So previously, we used the key symposium as a reference. We can see in 2004, the key symposium. And two other recently developed clinical classification systems identify as symptomatic, but non-demented stage of cognitive decline. They use a different terminology than NIA and AA criteria. NIA and AA criteria, that is what we often used before. So the international working group, like IWG criteria, use terms prodromal AD or pre-dementia AD to refer to individuals who have a cognitive impairment, but that is not severely enough to significantly affect daily activities, ADLs. And in the new DSM-5 refers to this stage as mild neurocognitive disorder. So they've been using different criteria all the time. It's kind of complicated to get an accurate prevalence of MCI among the populations. And this is a picture on the right side. So we can see nowadays, more and more biomarkers are being used if the patient is highly suspicious of Alzheimer's dementia. You want to rule out the Alzheimer as well. It's still under development, but it's getting more and more accurate. So this is a study of the brain function. The researchers, they did brain imaging studies to test people who have a normal cognitive, who have normal cognition and mild cognitive impairment and dementia, and compare it with a different spectrum. So several studies have indicated that individuals with the MCI who have a positive amyloid PET scan are more likely to progress rapidly to dementia. So for many years, it has been known that apolipoprotein E4 genotype are more likely to progress rapidly. However, in clinical practice, apolipoprotein E4 does not have a significant aiding to the diagnostic evaluation. So in general, medial temporal lobe atrophy on MRI tends to predict the progression. So it's the same thing as a hypometabolic pattern consistent with the Alzheimer dementia on FDG PET scan. So FDG PET scan on the right side, it shows from my understanding, it shows the metabolic in the brain. So we can see the red area. It gives you an idea of the high metabolic activity going on in this area. We can see from normal person, the red area is larger compared to the demented patient. And there is a new tau PET scan. So this is a newest tracer that is emerging, allows researchers and clinicians to evaluate the role of tau in clinical progression. So it's likely that a tau PT scan shows a spread of tau outside the medial temporal lobe into lateral temporal lobe structures. This means a poor prognosis and a rapid progression from MCI to Alzheimer dementia, but more data and studies needs to be done. So for the treatment, unfortunately, there is no pharmacologic treatment approved by FDA so far. This area is still under research. So we can also use Alzheimer's drugs, but the efficacy and efficiency is not being proved by many studies. According to Mayo Clinic, it's important to remove some reversible causes of MCI, such as some medications like benzodiazepine or antihistamine medications, and other medical conditions. You want to rule out the other medical conditions such as hypertension, depression, sleep apnea. So some RCTs show that there's no effectiveness at delaying the progression from MCI to Alzheimer dementia. It's very unfortunate. Also some lifestyle modifications like jogging, walking, or like swimming, aerobic exercise, mental engagement and social activity. These lifestyle modifications are possible protective factors for MCI. Studies also have shown that vitamin E may play a role in protecting MCI. So you also want to prevent cardiovascular diseases and stroke as well. This is a case study. I'm going to skip it right now. If we have more time, then I'll go back to talk about it. This is a case study that we saw last week. I'm going to talk about the public health issues. So this is a public health challenge for now. So as we talked before, many patients are ignored by the society and the family, even by themselves. So nearly half of the patients have never talked about their cognitive issues with a healthcare provider. So this is concerning and should raise the awareness in the public and medical authorities. So here are some thoughts about MCI and other dementia as well. Although we are going to we are going further and doing better in MCI and dementia criteria, here are some gray zones that have never been studied before. So we still need to improve the classification for MCI and develop the application of biomarkers. So we can do more studies on prevalence among the population, even the worldwide. Early detection of the dementia and MCI, early detection of MCI is very important because MCI still gives you a risk, 8 to 15% of risk of developing into a real dementia. So clear protocols and guidelines should be offered for screening. No approved FDA medications, so more studies need to be done in this area. And we also need to increase the awareness about the importance of managing chronic diseases such as cardiovascular diseases, stroke, among people with a cognitive decline. And also physicians should encourage patients to discuss any memory concerns during the visit. We need to educate like healthcare professionals about the importance of treating comorbidities and like be aware of any injuries among the patient with a memory loss as well. So we should also facilitate research to fill the knowledge gaps about intervention and the systems to benefit individuals with chronic conditions. All right, so we can, if we have time, then we can go back to talk about this case. This is a case that I saw last week. A 77-year-old female presented with a worsening memory loss for the past 6 years. And she has, after I got the history from her husband, I knew that she had gotten lost at least 3 times in the past 1 year in her neighborhood. So she was not, she was less, actually, she was no longer like managing her finances, but she denies any difficulty going to the bathroom, cooking, or getting dressed. These basic daily activities are not impaired. So her husband reports that she was diagnosed with MCI in 2014, and at that time her MOCA test score was 20. So physical examination, so that day we tested her MOCA score. It turned out to be 10. Her cognitive function declined. So during the mini-mental status, she couldn't answer the question for her age. When you ask her, how old are you? It took her about like 3 or 5 minutes to think about it. And Dr. Burnett, he did the physical examinations. There are 2 different special tests. There's one, we call it frontal grasp reflex. So when you touch her hands, she will forcefully grasp your fingers. This is a primary reflexes that are traditionally held to be a sign of disorders to affect the frontal lobes. So we usually see this reflex in newborn babies. And also the second sign is a snort sign. When you lightly typing on the lateral side of the closed lips, this will cause the mouth to purse, resembling a snout. So the lady, she had both of these tests positive. So in the end, Dr. Burnett, he get a review of all her blood work and to review if she has any vitamin D or thyroid function checked before. And we ordered a thyroid or vitamin D level in the end. So this is the case that I saw last week. I think it's interesting case to share with you guys. That's it. That's my presentation. Any questions, you are welcome to ask.